Hi everyone, welcome back to Learn with MedNuggets. In this video, we are going to talk about atrial fibrillation. Today we will be focusing on 7 things: the definition of atrial fibrillation, diagnosis, symptoms, etiology, classification, management, and the scoring systems of atrial fibrillation. So what is atrial fibrillation? In order to understand what atrial fibrillation is, first you need to know the normal conduction pathway of electrical impulses in the heart. Your normal heartbeat arises from the SA node, where it triggers the atria to contract, then moves through the AV node to the ventricles, causing them to contract and pump blood out of the heart. In atrial fibrillation, the electrical signals do not originate from the SA node. Instead, it arises from the pulmonary veins near the left atrium. Multiple ectopic foci in this area fire electrical impulses rapidly in a disorganized manner. These disorganized impulses cause atrial muscles to quiver rather than contract normally, which leads to loss of coordinated atrial contraction. In other words, a loss of P waves. Instead of distinct P waves, the ECG will show a fibrillatory baseline. The resulting abnormal atrial contraction will cause a disorganized, irregular ventricular depolarization, leading to irregular RR intervals on the ECG. Therefore, atrial fibrillation can easily be diagnosed by looking at a person's ECG strip. Palpating an irregular radial pulse is a helpful initial clinical sign that may raise suspicion of atrial fibrillation. In this kind of a situation, you can confirm it with an ECG. Atrial fibrillation patients can present with palpitations, fatigue, dizziness or lightheadedness, shortness of breath, chest pain, or syncope. So what causes atrial fibrillation? You can remember this with the simple mnemonic PIRATES: pulmonary post-op pulmonary embolism, ischemia, rheumatic heart disease, anemia, alcohol, thyroid, toxins, electrolytes, endocarditis, sepsis, surgery. We can classify atrial fibrillation into 4 different types depending on the duration of symptoms. Atrial fibrillation that is intermittent and lasts for less than 7 days is called paroxysmal atrial fibrillation. If it lasts for more than 7 days, it's called persistent atrial fibrillation. Atrial fibrillation that lasts for more than 1 year is called long-standing atrial fibrillation. And the kind of atrial fibrillation that you give up on is called permanent atrial fibrillation. So why is the duration of symptoms so important? Because your management depends on this. It's also very important to know the type of atrial fibrillation you're dealing with, as this changes the management plan altogether. We have 2 types of atrial fibrillation called valvular atrial fibrillation and non-valvular atrial fibrillation. Valvular atrial fibrillation usually refers to rheumatic mitral stenosis and mechanical valve replacement. This is treated with warfarin. And non-valvular atrial fibrillation is usually treated with direct oral anticoagulants. So how do you manage an atrial fibrillation? If the patient is unstable, you need to cardiovert the patient as soon as possible. If the patient is stable, you can start them on rate control and assess if the atrial fibrillation started in the last 48 hours or has it been greater than 48 hours. If it's less than 48 hours, you can cardiovert these patients. If not, you have to do a TEE and then you can do cardioversion. So why can you cardiovert if the atrial fibrillation has been present for less than 48 hours? The reason is 48 hours is not enough time for a clot to form. So if you cardiovert now, there's no risk of stroke. That's why if the atrial fibrillation has been present for more than 48 hours, it's wise to do a TEE and check if there are any clots before cardioverting. Because beyond that 48-hour mark, there's a risk of clot formation. For both these patient categories, however, you can also do a delayed cardioversion where you put the patient on anticoagulation for 3 weeks, then do cardioversion and give anticoagulation again for 4 weeks. The RACE-7 ACWAS trial, which was done in 2019, has shown that delayed cardioversion is not inferior to immediate cardioversion in achieving normal sinus rhythm at 4 weeks. So delayed cardioversion is also a good option. So earlier we were talking about rate control. What exactly is rate control? When it comes to treating atrial fibrillation, we have two options. We can do rate control or rhythm control. Which one is better? Well, the AFFIRM trial showed that both rate and rhythm control are equally effective. However, rate control is associated with less side effects than rhythm control. This is why almost all the time we start patients on rate control agents instead of rhythm control agents. With that said, there's a newer trial that you should know called the EAST-AF NET4 trial, which showed that rhythm control may be superior to rate control. This trial used a different set of drugs for rhythm control compared to the AFFIRM trial, so this could be a reasonable explanation for the differences in results. If I were you, I would definitely give this one a read. And that brings us to what are the rate and rhythm control agents. Rate control agents are things like metoprolol, diltiazem, digoxin, and esmolol. Out of these 4 options, metoprolol is an excellent option unless your patient has a history of reactive airway disease. Digoxin is a good option for a patient with hypotension or heart failure. However, it takes some time for the effects of this drug to kick in. Digoxin also has a cumulative effect on the body, which means there's a risk of developing digoxin toxicity. Rhythm control can be done with agents like amiodarone, flecainide, sotalol, or dronedarone. Amiodarone is our big gun. It has rate control properties as well. However, amiodarone can cause a lot of side effects and interact with other drugs as it is a CYP450 inhibitor. Generally, amiodarone is avoided in young patients due to its cumulative effects on the body. Whenever you start a patient on amiodarone, you should do a baseline PFT, TFTs, LFTs, and electrolytes every 6 months, and an annual chest X-ray. Flecainide and propafenone can be used in the pill-in-the-pocket approach, which is a strategy where patients can carry this pill with them and take it whenever they feel any symptoms of atrial fibrillation, like palpitations. This can help prevent any unnecessary ED visits or hospitalizations by converting an episode of atrial fibrillation back to sinus rhythm at the comfort of your home. Dofetilide and sotalol are generally last resort drugs. We give them to patients who have already failed multiple therapies. In the case of a pre-excited atrial fibrillation, meaning atrial fibrillation occurring with a pre-excitation syndrome such as WPW syndrome, procainamide would be our drug of choice. We also have surgical options to treat atrial fibrillation like the MACE procedure, where a surgeon creates a maze of scar tissue in the atrium to block abnormal conduction pathways and to kind of ensure that electrical impulses follow a controlled route. We can also do a Watchman procedure to seal off the left atrial appendage and reduce the risk of stroke in AFib patients who cannot tolerate anticoagulation. Catheter ablation is another minimally invasive procedure that ablates and creates scar tissue around the pulmonary veins, which are the source of atrial fibrillation. There are also two very important scoring systems that you need to be familiar with, which is the CHA2DS2-VASc score and Has-Bled score. This helps us to determine whether to start a patient on anticoagulation or not to prevent stroke in non-valvular atrial fibrillation. CHA2DS2-VASc score stands for congestive heart failure, hypertension, age more than or equal to 75, which carries 2 points, diabetes, stroke or TIA, which carries 2 points, vascular disease, age between 65 and 74, and sex female. If the total score is 0, no anticoagulation is generally needed. For a score of 1, anticoagulation can be considered. For 2 or more points, anticoagulation is generally recommended. Has-Bled score helps to assess the bleeding risk in patients with atrial fibrillation who are receiving anticoagulation therapy. It evaluates hypertension, renal and liver function, bleeding history, age, and medications or alcohol. Usually, if the total score is 0 to 1, the benefits of anticoagulation outweigh the risks and can therefore be used with routine monitoring. If the score is 2 or more, the bleeding risk is high, so the risks and benefits must be carefully weighed. Thanks for tuning in. Have a great day.